Back in the Dermcast studio with Rob Casquejo in Austin, Texas. I'm here today with a good friend and colleague, Shanna Miranti. She's here to talk about acne. So, Shanna, welcome to you. How are you?
Thank you so much. I'm wonderful, and I'm so appreciate the opportunity to be here.
Yeah, great. So we're gonna do this a little different today. We're gonna just play rapid fire. But before we do that, tell us a little bit about yourself and your backdrop as a clinician.
Absolutely. My name is Shanna Miranti. I have been a dermatology physician assistant for 20 years. I practice in Naples, Florida, and I see a little bit of everything, babies to grandpas and everything in between. And one of my absolute loves and passions to talk about, speak about, and to treat is both the conditions acne and rosacea. So I do have a passion for those skin conditions. I think we can make such a tremendous difference in patients' lives to be able to set them on a great course.
That's awesome. And so you're here to talk about acne today. And we know, the average clinician in dermatology, we see quite a bit of this. And so a lot of the finer details can sometimes get lost in muddled in our everyday practice. So let's start with a topic. People always seem to ask about this. And I think it's largely because there's no real guidelines on how to use the medicine. Spironolactone.
Great.
All right. So we're using spironolactone. We know we can use it, particularly in adult acne. Tell me where you use spironolactone in the case of acne.
Sure. So spironolactone has traditionally been used a lot in the female hormonal acne patient. And I do believe it's something that we see quite a bit of in our patients that are in their 20s, 30s, and 40s, and really even beyond. And it can really plague a lot of women beyond their teenage years. So it's something that a lot of people come in and ask questions about. Acne is the #1 diagnosis that we see as dermatology clinicians. So it is something that we really should embrace and should really love to treat, or at least learn to love it. And if you don't love it, fake it, because it's really important to try to be genuine, of course, but really give that patient some time and energy because they are really struggling with it. So it's something that I find patients will often come in and they've tried and failed a number of topicals. Spironolactone specifically is a great option for the female hormonal acne patient because it can really shut down a lot of the hormonal stimulation that we see.
Right. And you just mentioned failing medication. So are you getting to spironolactone typically after failed oral antibiotics, or do you like bringing it in right away with failed topicals along with antibiotics?
That's a great question.
Is there a rhyme or reason there?
Yeah. Oftentimes I will start patients, if I see that they have that traditional hormonal female acne, I'll start them on spironolactone right away, even if they have not even tried and failed any topicals. Spironolactone is a very readily available medication. It's typically available, obviously, in generic, and most patients have great access to it. I'll start patients on a 50 milligram dose and then usually work up from there. I do typically tell patients it's going to take 2 to 3 menstrual cycles to really see a difference because we need to block those androgens inside the skin, and it does take some time to see results. So tell your patients not to give up after 2 or 3 weeks of use. They're really going to need a couple months on drug.
Patience is definitely a virtue in that scenario. So we have, interestingly enough, we have a topical spironolactone, essentially, available to us on label for treatment of acne. Where does that fit in specifically with the use of oral spironolactone? Is there an overlap? Are they redundant? Do you have a feeling on that?
Yeah, great question. So the new medication Winlevi, which was FDA approved in 2020, I believe, for the topical treatment of hormonal acne, is a first-in-class androgen receptor blocker. And it's extremely exciting to have a topical that can achieve success in hormonal acne, which typically is a very stubborn type of acne to treat. I do not believe it's redundant. I do believe that the topical clascoterone does have additional efficacy, and I actually do use it on patients that are already on spironolactone therapy. It is a vehicle that's very well tolerated. It plays well with other things, and I love, obviously in dermatology, we all sometimes work a little bit off label and do put things together that were never studied together. But I do find that it plays very well with other topicals, but you do have to use it BID, I have found, to get great efficacy.
That's what the label tells us. And I wonder if there's value to having it on board with oral spironolactone when you take them off, that there's no transition or loss of of therapy from that molecule, maybe it sort of carries you over.
Yeah.
Maybe there's some value there. I wonder
I
if
think
that's
that's
the
a
case.
great point, you know,
Yeah.
because it is something that some patients just really don't want to be on systemic therapy if they don't have to be. I think it's fantastic that we have topical options, and just being able to potentially transition a patient that was on systemic spironolactone over to the topical clascoterone, I think is a really fantastic option that we really never had in our armament before.
Of course, and so spironolactone can be a lifesaver in adult female acne particularly. Where do you, if you're using spironolactone as a therapy, we know that sometimes folks get to the point, eating these adult hormonal female acne, they get to the point where it's just not going well. Isotretinoin becomes a clinical viability. Where do you draw the line with spironolactone in transitioning, or perhaps thinking about isotretinoin?
Sure. So I typically do want to see patients, of course, succeed, right? We all do, and we all want to get them clear because that's our ultimate goal. If we're not getting great clearance with the oral spironolactone on a lower dose, I will bump it up. My comfort zone is usually around 100 milligrams at most, because I do find that over that, we start to run into some side effects. A lot of women can handle a 200 milligram dose just fine, but there may be more dizziness, more dehydration, more interruption of menses, mid-cycle spotting, that sort of thing that does happen as we increase dosage a little bit. So when it becomes a problem where patients can actually not get to clearance, I do then start to talk about other therapies. But I, again, usually need to give it a good solid 3 months of use in addition to our topicals. Once we've been on spironolactone, maybe 3 to 6 months, and if you're not seeing good results, then we can transition over to isotretinoin. I, of course, would have them on an oral contraceptive. And I do recommend that women who struggle with hormonal acne get on one of the oral contraceptive pills that contains drospirenone. But as I said earlier, drospirenone, we have to remember, 3 milligrams of drospirenone is about equivalent to 25 milligrams of spironolactone in efficacy. So we have to take that into account.
Right. Smaller doses, yeah. But if they work, it's sort of, you get a benefit of perhaps another end goal with the therapy, contraception, et cetera.
Correct.
Okay. So what's the end game with spironolactone? When you get control, are you shooting to stop it? Are you shooting to do long-term low dosing? Do you have a specific end game within 6 months, 9 months, 12 months?
That's a great question.
Something there? Yeah.
You know, you'll find that patients are so excited about this therapy, and they really get true clearance. They don't get menstrual breakouts anymore, or at least a lot less of those pesky hormonal monthly breakouts. So they don't want to go off of it. They don't want to stop.
Right.
I have been able to transition some to the topical option now, but most women want to stay on it. There's benefit for even reduction in hair growth as women get older, or improvement of hair growth that we want, and decreased hair growth that we don't want. So women with PCOS and a lot of those types of conditions that really struggle with hormonal acne are not going to want to get off this medication. So I do have a number of patients that are controlled on therapy. I do practice pretty conservatively and do check a yearly potassium level, although that's probably not necessary anymore, but that's kind of old school. That's something that I've always done.
Sure.
But as long as they're doing very well, potassium is in range, and they are tolerating everything well, I am okay with them staying on it as long as we're on low dose, kind of extended long-term therapy.
So it sounds like you just addressed what I would have asked next. It doesn't sound like you have a lot of concerns for long-term therapy. Occasional electrolyte check, pregnancy can be an issue because we don't want them to be on it if they're pregnant. What about, hey, Shanna, we're talking about, we're trying. Do you stop? Do you?
Yeah, so that is always a great question, because a lot of times women will introduce a lot of other medications to become pregnant, and that can really flare acne. And women who struggle to conceive can often be giving themselves fertility drugs, which may really freak out their acne. So they get very scared to discontinue the spironolactone. That's definitely something that we have to have a conversation about, because I certainly want them off of the spironolactone as they get pregnant. I do tell patients that it's probably okay to take it up until that first positive pregnancy test, but if you're actively trying and you know that you are trying to conceive, then get off of it, and let's consider some topical therapies that are safer during pregnancy.
Okay, great. Well, those are some great angles on spironolactone, something that we like to use. There's just not a lot of solid guidelines, so it's good to talk about these things out loud. Let's turn our attention to more, let's say, the traditional treatments. There's some newer therapies out there.
A lot of them.
And, we have a lot of prescriptions for generic tretinoins and benzoyl peroxides out there. Not that I'm particularly knocking them. Sometimes it's all that's available according to formularies and things like that.
Sure.
But what's your take on somebody who is on a tretinoin, classic clindamycin regimen? They're sort of up, they're sort of down overall in their therapeutics. Where do you go when you see that patient? Where do you tend to go when you see that person walk in? And let's say insurance isn't particularly an issue.
Sure. So I do really try to cater my regimens for my individual patients. I never want to have a pre-filled out prescription in my mind when I grab for that door handle to walk into that room.
I think it's a great philosophy. I mean, sort of
sure.
per case basis.
Because you really have to take into consideration what they've tried and failed.
Yeah.
If they've already been to their pediatrician, they've already been to their primary care physician, and they've already been given generic clindamycin and generic tretinoin, then you can check that box. They've already tried that. They come to see you because they have not been successful with those medications. If they're happy on generic tretinoin and they've been on it for 20 years and they want to continue staying on it for anti-aging benefits or whatever, then go for it. Keep them on it if they're happy. But for patients who are frustrated and for patients who truly are not clear, there are so many options now. And we have so many fantastic options in our preteen space that we've never had before. So in 2019, I believe there were 4 drugs that came out indicated for age 9 and up. And that's very reassuring to parents and a lot of our helicopter moms that really want to make sure that their babies are being treated with the safest drugs possible.
And so talk through those therapies really quickly.
Absolutely.
Yeah.
So a number of different topical retinoids came out in 2019. Acleef, which is triferritine, was released in 2019, again indicated for age 9 and up. It is a 4th generation retinoid, and it's very photostable. So for those of us who practice in very southern states or in a very sunny area, it is something that you have a little bit.
Arizona,
Florida. Yep, a little bit of sunshine in both of our states.
Yeah.
So it is nice to have some dosing options if patients don't always want to use something only at nighttime. That is something that is photostable. Now, they may be photosensitized by topical retinoids in general, of course. So we need to be preaching our sun protection always. Okay. But it is a photostable retinoid, which is very exciting.
Okay.
In addition, Raslo was another drug, a topical tazarotene at a 0.045 percentage. Very, very well tolerated. It is also photostable. It's a 3rd generation topical retinoid, very well tolerable.
And it's a lotion, which we had never had with tazarotene.
Yes.
We had foams, gels, creams.
Exactly.
Never a lotion.
Exactly.
Right.
So, and the spreadability of it is fantastic. There's spreadability data for truncal acne. Acleef also has truncal acne data. Amzeeq was another topical that came to market, which was very new and novel because it was a topical minocycline foam. I say it with past tense, although it's still out there. We still love it.
Yeah.
But that is also a very spreadable topical, which works very well to kill microorganisms and reduce inflammation. It can become miscible with sebum and really help to kind of break down some of those comedones as well. Sacera was also a drug, an oral an oral antibiotic that was introduced, again, with an age indication of 9 years of age and older. I still, just to pause on that, just the new news for a second, I always do look at kids' dentition, of course, as we all probably do, but we do want to make sure that we look at and document adult dentition in place, make sure we're asking, do they have any baby teeth? Have most of their baby teeth fallen out before starting any systemic antibiotic therapy? But I do believe it's something that, it is important to make sure that we document. But we have safety data from 9 years of age and older, which is great.
So in being published, it makes you feel a little bit better, but still, I like to say that in medicine, you never say never, you never say always.
Correct.
So just make sure is the key.
Absolutely.
That's
and then
fantastic.
one of the newest, latest, greatest that was actually just released this year is Twinio, which is a combination of 2 medications that we know and love, tretinoin 0.1 and benzoyl peroxide. And although these are 2 kind of older drugs, right? These are more antiquated medications that have been out for a very long time. This is a perfect example of 2 medications that never played well together. In fact, benzoyl peroxide, when applied to any generic topical tretinoin, will oxidize it and break it down, and it won't work very well.
Sure.
So we might give patients things to use at home and tell them to separate them. But of course, maybe they don't. Maybe they pile things on top, and maybe they are degrading the therapies that we're trying to build and to kind of be successful. So this is a very exciting topical therapy, taking some of older drugs that patients maybe or providers and clinicians really have a lot of faith in, and it's formulating it in a brand new way.
Great. So let's end with the compliance issue, because I think you just hinted towards it. What are your best hitters or your quick hitters for compliance issues? Whether it's taking a single medicine, multiple medicines, staying on track with the therapies. What do you got for us?
Sure. So I really think you have to take the time to get to know your patient and ask them, what do you want? You know, what do you want? A one-time, once-a-day therapy? Do you want a pill? Do you not want a pill? You know, what is your ultimate, perfect therapy in mind? And really kind of engage the patient a little bit and find out what they think they need to be successful. Because some patients have 2 comedones and 1 Accutane, and that's just not the correct way of treating. So then we have to speak with them a little bit about expectations and kind of managing, just because their best friend or somebody on their sports team got clear skin from one drug, it may not be the perfect drug for them.
Sure.
So I think getting to know your patients and finding out if they are a very diligent patient who will do things multiple times a day, will use multiple different medications, and will use them in a special order, then great. Set them up for success, and let's get some great products on board. I think your adult females love a regimen, right? They love a good 3-step, 10-step, 7-step series, Your teenage boys will never do that in a million years. So I think keeping it simple for certain age groups is critical, because otherwise they're going to get frustrated, and then they're going to think medications don't work when they truly just weren't compliant with them.
Right, and it's something you have to call them out on.
For sure.
So you have to bring them back to a place where, hey, to understand that you have to use it, or else
it doesn't work if it sits on their bathroom counter.
Amen. Yeah, it's the easiest way to say it.
For sure.
Well, that's fantastic. Let me ask you one more question,
Sure.
because I think this is commonly asked. Is there something over the counter you like to use in whichever scenario it is? No insurance, expense is an issue, accessibility, whatever the case. Is there something that you have a go-to over the counter?
So there actually are some over-the-counter regimens. Good old-fashioned Differin, that was, the adapalene that was out a long time ago when I first started practicing, is now over-the-counter. So it's an exciting product to be able to send a patient to Target and they can go pick it up, or they can pick it up from their local drugstore without a prescription. And that is a safe medication to be able to use, even with planning pregnancy, et cetera. So that is something that they might be able to be successful with. There are a lot of benzoyl peroxides, salicylic acids, glycolic acid serums, and washes that are going to be helpful for managing some of the sebum and some of the buildup of oil.
Sure.
I don't typically go to a lot of the infomercial type things, or the kits. I tend not to send my patients that way, although they can be very successful with a proactive and what have you. But it's benzoyl peroxide and salicylic acid, so it's not truly very magical. So I do tend to want to talk to the patient about, hey, what's reasonable, what can we afford? If you don't have insurance, maybe there are some compounded prescriptions from compounding pharmacies that can be very affordable.
And I think that's a good point, because compounding pharmacies have made some, at least the generic retinoids, for instance, you can get them at very reasonable prices.
Correct.
So it may be good.
And a lot of specialty pharmacies do have, and even with GoodRx, there are some really good cash options out there.
Yeah, very helpful.
And remind patients that 1 tube does not equal 1 month of therapy. A lot of times they will get multiple months out of a 30-gram tube or out of a 45-gram tube. So it's not going to be a huge cost per month.
Excellent. Thank you so much, Shanna. This is all this good stuff. This stuff that can get lost sometimes in translation with therapy. But thanks so much for stopping by the studio and hanging out with us.
Happy to be here.
And we need to catch up more often.
For sure.
Yeah, and thanks for supporting SDPA as always.
Absolutely.
All right.
SDPA.
From Austin, Texas, thanks for watching Dermcast TV. It's Rob Casquejo with Shanna Miranti.